Let's look at subacute to chronic in repair phase 2 going into repair phase 3. So symptoms here now are typically more intermittent. They're less irritable. They're more tolerant to the movement. And movement loss is still present. You will see the obstruction to motion still there. Your tolerance is better. They can push into it. It might still pinch that nerve a bit, but it just sort of calms down fairly much easier. Not as much long-lasting worsening symptoms. So mechanical pain now is dominating the picture. So then now our goal is, well, can we start to restore movement and function? So think about the people who are not painful. They have full motion, normal movement, nothing hurts. These people have obstruction to movement typically. It's very painful and it pinches. So if you can get that joint to move normal, then nothing's going to pinch on it. So you kind of have to think about it that way. It's like, well, can I now get this joint moving better? And now we've got the MDT, red light, yellow light, green light. How much can we push into this? Well, if we pay attention to the symptoms, we will know if we pay close attention. So our goal is to restore the motion. How are we going to do this? Is we're going to address the impairments that they have. So how do we do that? It's going to be through what type of range of motion. If we can work into the obstruction, then it just very easy, like just bump into that obstruction, you may get an increase but no worse effect. That's what we want, or produce not worse effect. Then the question is, if we can do that, not make them worse, then what's the right dosage? Well, that just depends on the tolerance. Maybe it's 5 reps 3 times a day. Maybe it's 3 reps 5 times a day. Maybe it's 10 reps 3 times a day. So it really just depends on what that nerve and what that tissue can handle, what the patient can handle, how quickly it calms down. So we'll learn that information in the clinic. And then the question is, well, should I go lateral first or sagittal first, right? Should I look at the lateral movements before the sagittal movements? If there's a large lateral obstruction, then I'm going to start working lateral first. Trying to clear the lateral compartment, get that moving with better quality and less pinching of the nerve, and then gradually bringing in, the sagittal plane movement that's obstructed. We talked about dosage. That depends on the patient. But then we also, if that doesn't work, it's like the more you push into it, the worse they feel, then that's not an option. So then you got to look at, well, what about opening up the space? I have used opening up the space with rotation and flexion. I have used flexion and step standing for some of these people, and I've looked at inflection. And what happens, you open up this space, you give it enough room, it calms down, and then finally I can now start working into the obstruction. And then you do both. Maybe you go open up and then a little bit of closing down, or closing down and then a little bit of opening up. So you've got so many different options. It's just finding what the problem can handle. And then you look at maybe slouch over correct at mid-range, but working towards end range, like pushing into a little bit of that pain, but not too much. You could, and then decide like how much dosage. I've had some of these people just use slouch over correct and gradually get significantly better. And movement starts to restore itself. And what happens is, as these people get better, as time goes by and you've got this environment of working through the impairments and trying to recover motion, symptoms get less intense. You can tell healing is taking place. Movement quality is getting better. Movement is starting to get more normal, not as pinchy, not as obstructed. And then you've got to also consider, as you're working through this and you're going about every 10 days to 2 weeks, the question is, are they starting to show signs of maybe becoming a derangement and actually having a directional preference? And all you have to do is take a few of those repeated movements and test it. And you will find those that are becoming derangements that now are starting to centralize. And then some won't, and some will. You just have to be attentive to testing and making sure that you're not missing anything. But all along the while, patients generally, you'll see changes probably about 10 days to 2 weeks. That the change is noticeable. and a little more obvious. And then you start getting into function. Once they can tolerate weight bearing better, they're not as irritable, they can tolerate movement better, then it's time to start conditioning, and you start light and more neutral exercises. It might be upper body conditioning, even for a lower body problem. Just getting some activity. It may be walking. It may be then progressing to squats and heel raises and lunges, and more functional type of exercises. And some that are really not tolerating weight bearing yet, but you want to see if they can do a little bit of conditioning. Maybe you do some lying down conditioning and getting them a little bit more active. Maybe it's a leg lift. Maybe it's sideline hip abduction, just something simple, something that really just kind of starts the process of being more active. In the later stages, you may have to start working on neural tension, neural glides and stuff like that to get the nerve moving better and tolerating movement better. So that's, you'll move into those types of exercises. And our expectation is if they're recovering, you will see an increase in motion and decrease in frequency, duration of symptoms, and improving function. And you will just keep going in that direction until they have full motion, full recovery.